Good morning, ladies and gentlemen. The topic of today's lecture is Hideradenitis suppurativa. The name Hideradenitis suppurativa, which include the words adenitis, is a misnomer. It is derived from the historical hypothesis that Hideradenitis suppurativa is related to inflammation of the sweat glands. But now it is proven that Hideradenitis suppurativa is a chronic, inflammatory, recurrent, debilitating follicular disease that usually presents as painful, deep-seated inflamed lesions in apocrine gland-bearing areas of the body, which are most commonly axilla, inguinal, and anogenital region. So previously it was thought that Hideradenitis suppurativa is an apocrinitis or an inflammation of apocrine glands, but now it is proven that Hideradenitis suppurativa is one of the follicular occlusion disease, which is characterized by the prime feature, which is obstruction of the hair follicle. Severity of Hideradenitis suppurativa is judged by Hurley stages, which are often used to direct therapy. And the Hurley stages will be discussed later. There are three criteria which are must for the diagnosis of Hideradenitis suppurativa. The first criteria is the typical lesions, which are deep-seated, painful nodules. These may be called as blind boils because there is no pus pointing, or abscesses, draining sinuses, bridged scars, and paired or multi-head open pseudocomedones. So these are the typical lesions. Then these typical lesions should be present on typical sites, and the typical sites are axilla, groin, perianal region or perineal region, buttocks, infra and intermammary folds. Then the third or the final criteria is the chronic and recurrent nature of these lesions. So one such attack would not be sufficient to call it as Hideradenitis suppurativa. So there has to be this multiple recurrent and chronic lesions. Complication of the severe disease include contractures, then anemia, lymphedema, and squamous cell carcinoma. The psychological impact of the disease is quite severe and does affect severely the quality of life of the patients, which is much more than any other inflammatory dermatosis. Management of Hideradenitis suppurativa is always challenging, and the treatment has to be prolonged, and the treatment has to be combined with medical and surgical approach. Incidence and prevalence of the disease. The annual incidence of Hideradenitis suppurativa is somewhere around 100,000 persons per year in US. The average age of the sufferers is 24.2 years plus minus 12 years. And the disease typically present at or around puberty. Women are more frequently affected than men, and the ratio is 2.7:1. Then perianal and gluteal disease is more commonly affected in males, while female, the disease is more frequently seen in genitofemoral and in submammary regions. There is no known ethnic predisposition. Associated diseases. Many different diseases are associated with Hideradenitis suppurativa, and the first and foremost is the follicular occlusion triad or tetrad. The follicular occlusion triad or tetrad include acne conglobata, dissecting cellulitis of the scalp, pilonidal sinus, and Hideradenitis suppurativa. All these four diseases are characterized by the first and primary abnormality of follicular occlusion. Then several inflammatory dermatoses are associated with hidradenitis suppurativa, and the significant include Crohn's disease, peripheral ulcerative keratitis, and HLA-B27 and RF factor negative inflammatory spondyloarthropathy of axial and appendicular joints. Then there are a few inflammatory syndromes which have hidradenitis suppurativa as one of the feature. These inflammatory syndromes has the most typical feature that all of these syndromes are characterized by severe acne or pustular acne or acne conglobata. The first is the Sappho syndrome. Sappho syndrome is abbreviation of synovitis, acne, pustulosis, hyperostosis, and osteitis. So joint involvement is not there, but only bone pain and bone involvement is there. Then Papa syndrome. Papa syndrome is characterized by pyogenic arthritis, pyoderma gangrenosum, and acne. Then PASH syndrome. Now, in PASH syndrome, pyoderma gangrenosum and acne is associated with hidradenitis suppurativa. And PASH syndrome, in addition to the above three diseases, that is the pyoderma gangrenosum, acne conglobata, and suppurative hidradenitis, we have pyogenic arthritis as well. So as I have highlighted in these syndromes, acne is a feature of all the four syndromes. Pyogenic arthritis is a feature of Papa and PASH syndrome. Pyoderma gangrenosum is seen in three of these syndromes, Papa, PASH, and PASH. And hidradenitis suppurativa is seen in the last two syndromes, that is PASH and PASH. Few genodermatoses are also associated with hidradenitis suppurativa. These include keratitis ichthysis deafness syndrome, KIT syndrome, pachyonychia congenita, steatocystoma multiplex, and Dowling-Dego's disease. Pathophysiology. Earlier studies implicated apocrine gland occlusion as a primary pathological event. However, the histopathological observations have now demonstrated that follicular involvement is central to pathogenesis. And following is the sequence of events in pathogenesis of hidradenitis suppurativa. The first is in fundibular hyperkeratosis, leading to follicular occlusion. Then it causes the dilatation of the follicles distal to the hyperkeratosis with cyst formation. As the dilatation increases, the follicle rupture and the keratin and other follicular contents are released into the dermis, causing subsequent inflammation and later on fistula formation. Predisposing factors. The two most important predisposing factors to hidradenitis suppurativa are obesity and smoking. 69 to 77% of the patients suffering from HS are grossly overweight or obese. Increased pro-inflammatory cytokine release from visceral fat, physical occlusion, and epidermal barrier stresses at the intertriginous site may play key role in predisposing hidradenitis suppurativa in these patients. Then 63 to 93% of patients are smokers, but it is not sure if stopping the smoking would cure hidradenitis suppurativa. Hormonal influences. Usually there is no much differences in androgen metabolism in patient of HS. There is a perimenstrual flare of the disease and the disease improves in pregnancy. There are not much signs of virilization and circulating androgen levels are usually normal. There is some studies which show an aggravation of hidradenitis suppurativa while using lithium or sirolimus therapy. Host defenses. It is known that there is some alteration in innate immune system, but there is no major immune abnormality. There is significant decrease in toll-like receptors and relative deficiency of range of antimicrobial peptides. So the reduction in antimicrobial peptide result in increased proliferation of not very virulent pathogens. Several inflammatory and anti-inflammatory cytokines are elevated in hidradenitis suppurativa. So those cytokines which are elevated in HS include interleukin-1 beta, tumor necrotic factor alpha, and interleukin-10. And those cytokines whose levels are very low or negligible include interleukin-2, 4, 5, and 10, 2, 4, 5, and interferon gamma. As far as the interleukin 20 and 23 and 17 pathway seems to be activated, just like in psoriasis, with enhanced expression of interleukin 17A, interleukin 12, and interleukin 23. Now, histopathology. As you can see in this picture, this is a dilated hair follicle which is completely occluded by the keratin debris. So this is the follicular occlusion, which is the first and foremost feature in patient of HS. And there is intense perifollicular lymphohistiocytic infiltrate surrounding the hair follicles. Then this picture shows the spillover of inflammation in apocrine glands, which is although a feature noted in histopathology, but it is not the prime abnormality. And now in this picture, the follicle is ruptured and there is the inflammation in the dermis is much increased than the previous picture. And later on, there are sinus tract lined by stratified squamous epithelium, and the sinus tract contain the keratinous debris hair shaft and surrounding fibrosis and inflammation. The causative organisms. Hideradenitis suppurativa is currently regarded as a primary inflammatory disorders without a defined infectious trigger. And usually the culture from such lesions is negative. But if the culture is positive, then the grown microorganisms are usually Staphylococcus epidermidis or Staph aureus, followed by Peptostreptococci and Propionibacterium acne. Genetics. Approximately 1/3 of patients have a family history of HS. HS does not seem to be linked to any HLA type. In some cases, an autosomal pattern of inheritance can be found. Environmental factor. Mechanical irritation and shear forces are potential contributing factor. So those patients who are having some jobs in which there is increased sweating and increased mechanical irritation, there is increased predisposition to HS. Further, poor hygiene and variation in routine depilatory techniques and use of antiperspirants are also related to HS. Clinical features. A typical index lesion of HS is a painful subcutaneous nodule or abscess that persists for a relatively long duration, that is more than 7 to 15 days. This is usually followed by spontaneous regression or partial regression or progression to abscess formation with rupture and release of purulent malodorous discharge. The lesions are typically in the flexural areas, and the commonest sites are axilla and inguinal region and anogenital region. And anogenital region include the external genitalia, the perineal lesion, perianal lesion, and gluteal skin. Then submammary, inframammary, and intermammary area is also affected by hidradenitis suppurativa. Less commonly, retroauricular, preauricular, and occipital skin are also involved. Truncal variants are also reported. The another feature is chronic or recurrent nature of the lesion. So recurrence take the form of acute, intermittent, or continuous disease involving new sites or new lesions on pre-existing sites. The period of remissions lasts for weeks and months. The continuous active disease lead to coalescing of the nodules and formation of sinus tracts with a chronic daily purulent discharge and pain. Scarring, when developed, it is typically bridged or rope-like. It can be hypertrophic or atrophic, producing depression, especially on the buttocks, and associated with contracture. So it leads to gross destruction of the flexural skin and many raised and depressed lesions. Pseudo-secondary comedones are seen, and closed comedones, and closed comedones are not seen. So this is a typical initial lesion of hidradenitis suppurativa, which is a nodule or a boil-like lesion. Now, this is the gradual progression of the disease from a small nodule to a few sinus tract, and then scarring, and scarring is rope-like. You can see the long scarred areas. And a lot of inflammation and abscess formation. So all the skin is quite jumbled up. That's why such kind of infection never goes and requires surgery. The clinical variants. The three variants which are commonly seen, the first is the classical variant, which is the typical features, that is the presence of abscess and sinuses in typical sites. Then the second variant is characterized by additional involvement of ear, chest, back, or leg with pilonidal sinus and with severe acne and family history of HS. Then third variant is characterized by gluteal involvement and is more common in men. Differential diagnosis. The index lesion may be confused with usually bacterial abscesses, carbuncle, or furunculosis, usually staph or strep infection. Then secondary infection of cysts like epidermal inclusion cyst or Barthorian gland cyst may be confused with initial lesions of hidradenitis suppurativa. Then Crohn's disease result in inflammatory abscesses, sinus tracts, and scarring, usually at the perianal site. The fistulas of Crohn's disease are connecting to the anal mucosa or rectal mucosa, but hidradenitis suppurativa sinuses are only limited to the skin and does not have any opening in the gastrointestinal tract. Then the chronic infectious granulomatous diseases like tuberculosis, sporotrichosis, actinomycosis, and lymphogranuloma venereum may be confused with chronic lesions of hidradenitis suppurativa. Steatocystoma multiplex and neoplastic disease like Langerhans histiocytosis should also be considered in the differential diagnosis. Then the Hurley stages in hidradenitis suppurativa. So this staging system is important to grade the disease, the condition, and plan the treatment. Stage 1 is recurrent abscess formation without sinus tracts and cicatrization. So it's the only feature is the recurrent abscesses. Stage 2, in addition to the recurrent abscesses, there is sinus tract and which are widely separated from one another with some degree of cicatrization. While stage 3 is the most severe disease, which are characterized by multiple interconnecting abscesses, then interconnecting sinus tracts, and cicatrization, which is diffusely involving the region. So you can see this is the first stage 1. Then there are few sinus tracts and few abscesses and scarring, but now the sinus tracts are interconnecting. Scarring is much more prominent. Lesions are quite large in number. Then few other scores. One is the hidradenitis severity score or modified Sartorius score. The HSS or modified Sartorius score is a more detailed, validated, and dynamic score used to assess both the severity and the treatment response of hidradenitis suppurativa. It correlates with the Hurley score, but is more precisely defined and responsive to change. So this score incorporates assessment of number of anatomical sites, counts of inflamed and non-inflamed lesions and nodules, count of the sinus tract, extent of involvement in a given region, and then it leads to a total. So this is quite an elaborate score. Then hidradenitis suppurativa clinical response, HISCR. This is an outcome measure when studying the treatment. And this is defined as more than 50% reduction from the baseline in number of inflamed lesions without a concomitant increase in number of draining fistula. Patients who achieve HISCR appear to have meaningful improvement in their disease. Complications and comorbidities. So the first complication, the most commonest complication, is a superinfection, which is suspected when there are flares preceded by stinging or pain or sharp pain, fever, and development of pustules and other superficial lesions. Then long-standing chronic disease leads to obstruction of lymphatics and lymphedema. Lymphedema is seen in the surrounding skin. The anogenital side is more severely affected, which progress to scrotal elephantiasis and is confused sometimes with lymphatic filariasis. Then fistula formation to gastrointestinal tract, which is usually not a common occurrence in HS, but may develop as a complication. Even in genitourinary tract, like urethra, bladder, and vagina, and peritoneum, all are quite rare complications. Then long-standing hidradenitis suppurativa are liable to develop SCC and carries a poor prognosis, and it is reported more in men than women. Then some systemic side effects include anemia, hypoalbuminemia, hypergammaglobulinemia, and rarely systemic amyloidosis and sacral bacterial osteomyelitis. As explained before, significant psychological impact of the disease and social and economical impact is also there. And depression is seen in more than 40% of the patients. Disease course and prognosis. Chronicity is hallmark of the disease, and mean duration is 18.8 years. The milder form, that is Hurley stage 1, is more frequent and report in approximately 2/3 of the patients. Then the intermediate disease, that is Hurley stage 2, is seen in 1/4 of the patients, and severe disease is seen in 1/5 of the patients. With increased age, there is a spontaneous remission of the disease. Investigations. Usually the microbial studies are not much helpful. Histopathology is indicated sometimes in refractory or atypical cases. The imaging like ultrasound or MRI defines subclinical extension, but otherwise does not contribute much in the diagnosis, which is mainly clinical. Then routine blood tests in severe disease may reveal anemia, hypoalbuminemia, and hypergammaglobulinemia, and elevated C-reactive proteins. All are the inflammatory markers which can be used to judge the clinical response to treatment. Management. The management strategies depend upon, number one, the need of the patient. Some patients have milder disease, but they are much more disturbed and require definitive treatment. Since it's a multifocal disease, a generalized medical treatment is more appropriate. Once scarring occurs and the affected skin is grossly damaged, then surgery is the only option. Non-specific measures include weight reduction and number two, tobacco abstinence, and patients should be taught how to use bandage supporting lesions, how to bandage the supporting lesions, and recommend to wear loose fitted clothes. The lesions are quite painful. The patient may require analgesics. Topical therapy. For early lesion, clindamycin 0.1% is beneficial. For recalcitrant and established lesion, topical resorcinol 15%. Then there is benefit of using chlorhexidine washes and benzoyl peroxide. Systemic antibiotics. So the first systemic therapy in hidradenitis suppurativa will be antibiotics. And the antibiotics will be in a form of treatment will be as we do in acne. And the first antibiotic of choice is tetracycline, 500 milligram twice a day for 3 months. Vibramycin can be used instead. For advanced disease, a combination of clindamycin and rifampicin is worthwhile, while in more severe disease, rifampicin may be combined with metronidazole and moxifloxacin. Then anti-inflammatory lesions, small lesions respond to intralesional triamcinolone, usually 3 to 5 milligram per 3 to 5 milligram per ml. For more severe disease, where we can advise a short course of prednisolone, 0.5 to 1 milligram per kg body weight, or cyclosporin, 3 to 5 milligram per kilogram body weight, or even a long-term dapsone therapy. All have anti-inflammatory role. Biological agent. Tumor necrotic factor alpha appear to be beneficial effect in severe HS, and among them adalimumab in a dose regime similar to inflammatory bowel disease with a loading dose of 160 milligram at week 0 and 80 mg at week 2, followed at week 4 by 40 mg every week for a total of 12 weeks. Infliximab, etanercept, and ustekinumab are also good in treatment of HS. Retinoids. Isotretinoins are rarely effective and its use is not encouraged. On the other hand, acitretin 50 mg daily is preferred. But of course, we cannot give acitretin to female who are married and childbearing age. So in such cases, the retinoid of choice would be isotretinoin. Experimental therapies include zinc gluconate, 90 milligram per day. And other treatments include intramuscular immunoglobulin, metformin, and even botulinum toxin. Incision and drainage is done and useful only when frank fluctuating abscesses are seen. De-roofing is a minor surgery where the roof of the abscesses is removed surgically or by electrocautery or by conventional surgery exposing partially epithelialized granulating floor of the lesion. The ensuing defect is left open and to heal by secondary intention. Localized surgery. Single lesion can be excised surgically, suggesting that wider excision have a better result than more limited excision. Ablative laser and electrosurgery. CO2 laser evaporation of visibly affected tissue may be helpful, and the technique offers radical treatment with little tissue, with the tissue sparing. It normally heals sufficiently for resumption of work in 2 to 3 weeks, but may take 8 to 10 weeks for complete reepithelialization. Patient satisfaction is usually high. Then comes the extensive surgery, which can be labeled as vault excision or total removal of the skin of the flexures. This is particularly done in stage 3 Hurley stage 3, and with patient of multiple interconnecting sinus tracts, and is only curative method in excision of entire involved area. Often large defects can be left to heal by secondary intention. Usually in bigger surgeries, we don't close the lesion because there are chances of infection as well. So the lesions are left open for secondary healing by secondary intention. With daily antiseptic dressing and oral antibiotics, the patient attention should be paid on mobilization of affected areas to avoid post-operative stricture. So this is a surgery which is performed by myself. So you can see this interconnecting sinus tracts and abscesses. So the whole vault skin is removed and the lesion was left to heal by secondary intention. Non-ablative laser or IPL. Hair removal using light-based therapies appear to have some beneficial effect in HS. Then radiotherapy. In recalcitrant disease, radiotherapy may be considered. Fractionated radiotherapy is described. Total dose of 12 grays have been administered as a single dose of 0.5 to 1 gray and given 4 to 12 times. This brings to end of this talk. So I am thankful for your patient listening and see you next time with another edition of my lecture. So goodbye for now and have a good day.